Good afternoon, everyone. We're going to try to stay on time. Hello, my name is Ann Spinard, and this afternoon we're going to be talking about Section M, skin conditions and pressure ulcers and injuries. So the same framework that we've had all morning. We have the acronym list. And so they're all here for which we're going to be using in this presentation. And let me just pause for a moment for those of you who are watching live streaming. Please remember to go to your landing page from which you are watching the live streaming, and the first link, and it will download a zip file. We are session 6, and there's two things that say section 6. One is a coding scenario worksheet, and for those of you in the room, I think it is on the you open up your folder on the right-hand side. So if you can pull those out in anticipation of the presentation, we don't need them right away, but just kind of pull them out and have them off to the side. And for those of you that are watching live streaming, if you want to print them out, we'll be using it about halfway through the presentation, and it's an easy way to follow along and actually practice some of your coding. Okay, everyone have theirs? Yes? So in our overview, today we're going to define skin conditions. We're going to talk about the intent of Section M. We're going to talk about new items or changes in the long-term care hospital continuity assessment record and evaluation or CARE data set. And we're going to compare version 3 to 4.0. And we're going to discuss the coding instructions needed to inform for the items. And we're going to spend a fair amount of time doing some practice scenarios, because we find that those are, especially with skin, I think are the most valuable. By the time that we finish this program, hopefully we'll be able to state the intent of the changes to Section M. They're not major, which is good. We're going to describe the new pressure ulcer injury quality measure. And we're going to be able to hopefully be able to have you articulate the purpose for the new wording and any implications for the coding, and to apply coding instructions to accurately code the practice scenarios, but more importantly, to be able to actually complete the data set accurately. So the intent of this section is to document the presence or appearance or change in the status of pressure ulcer injuries based on a complete and ongoing assessment of patient's skin, guided by clinical standards. And this will hopefully promote effective pressure ulcer injury prevention and skin management programs for all patients. And so we need to kind of start the day and say, what is a pressure ulcer/injury? Well, the first thing you'll note is that word ulcer/injury. If you were at previous trainings, we didn't have the word injury in there. So that's one of the changes that we'll be going through. But it is a localized injury of the skin and or underlying tissue, usually over a bony prominence, and as a result of pressure or pressure in combination with shear and or friction. So that's a key concept. It's been interesting as I've taught this section in a variety of the different post-acute settings, but even my counterparts working in acute care, the ability for staff to understand and be able to stage what is a pressure ulcer and what is something else. Moisture-associated dermatitis, is it a diabetic ulcer, is it a stasis ulcer, is it an arterial ulcer? So it's really important, because it's amazing how many people are saying, well, we have all these pressure ulcers when it's moisture-associated dermatitis, and in fact, or some sort of a yeast type of infection that is not pressure-related. So the key indicator when you go back to your facilities, one is to say, let's not code it in this section unless pressure is related, which means you need to be able to relieve the pressure, right, as part of your plan to be able to progress this to a healing state, if possible. And I would challenge you, and if you heard me speak the last time, especially to this group, but all of the other post-acute settings, I said the same thing. How confident are you today in your staff's ability to be able to identify and stage a pressure ulcer? It's worth the effort. It's worth the time, it's worth the effort to investigate that and to ensure that what you have, in fact, is pressure related for this particular section. But it's going to help you in your treatment. I tell this story. I was once in a facility, and they were struggling with some of their skin issues, and the facility staff said, we have this gentleman, elderly gentleman, who we just can't seem to heal this ulcer towards his coccyx area. Could you look at it? So I went down with the staff, and I met this gentleman walking down the hallway, and I said, I introduced myself, we walked into his room, and I said, and the other nurse was with me, and I said, I heard you have this ulcer, and I was wondering if we could take a look at it and see if we can come up with a different treatment plan. He said, I've had that darn thing, he said, for like 6 weeks now. And I realized he's up, he's about, he's alert and oriented, he's in normal body weight, and he eats well, and he drinks well. What do you think's wrong with that picture? Probably shouldn't have a pressure ulcer, right? So I said, is he sitting around? What is he doing? They're like, nope, he doesn't do any of those things. So we took a look at the ulcer. He, in fact, had a yeast infection going on, and it was a very classic yeast infection. So they treated it, and it went away. But they had been treating it as a pressure ulcer and coding it as a pressure ulcer. But I said to the staff, what were you removing pressure from? Like, what were you doing that was relating to pressure? And they said, well, it looked like a pressure ulcer. I said, but it was missing one main component. And they looked at me and they said, what? I said, pressure. So, we kind of laugh on that, but when we think about this and how important and how really significant pressure ulcers are, we want to make sure that we're accurately coding, right? All right. So this is what we're looking at, changes in skin integrity, post-acute care, and pressure ulcer injuries. So the changes in this particular item, we have M0300 will be used to calculate the new quality measure, change in skin integrity post-acute care, pressure ulcer and injury, so that's the item. And the data collection will begin on July 1st, 2018. So you have, 6 months, almost 7 months, to make sure that you have this correct in your organizations, and I encourage you to do that. For this measure, an ulcer is considered new or worsening at discharge if the discharge assessment shows a stage 2 through 4 or unstageable pressure ulcer that was not present on admission at that stage, so whatever stage it was on admission. So meaning that if the ulcer has progressed in its stage or is now unstageable, we're going to be coding that in this particular measure. So it's always important to understand our numerators and our denominators. So our numerator stays in the denominator in which the discharge assessment indicated one or more new or worsened stage 2 through 4 pressure ulcers or unstageable pressure ulcers compared to admission. So it's discharge compared to admission of what they had. The denominator for this are patient stays with both an admission and a planned or unplanned discharge. So we can't have this measure, right, if we don't have a discharge assessment to compare to the admission assessment. And there will be a few exclusions, and we're going to go through those exclusions. And the exclusions are the patient stays excluded if data on new or worsened stage 2 through 4 and unstageable pressure ulcers, including deep tissue injuries, are missing on the planned or unplanned discharge assessment. So if for some reason you don't capture the information on your discharge assessment, we can't use it. It makes sense, right? And then patient stays excluded if the patient died during the stay. So that's an absolute exclusion. So the time frame. So how is this going to be reported? Well, the measured time frame window will be calculated quarterly using a rolling 12 months of data. For public reporting, the quality measure score report for each quarter is calculated using 12 months of data. So as a new quarter comes in, the oldest quarter drops off. So it's always a rolling 12 months. It just moves through. All LTCH stays during the 12 months, except for those that meet the exclusion criteria, are included in the denominator and are eligible for inclusion in the numerator. So anyone who had an admission assessment and a discharge assessment, excluding ones that died in your facility, will be, and met the other criteria, will be included in that quarter's data. And as that moves in, again, that will be your new quarter's worth of data, and the oldest quarter will fall off. So it will change over time. For patients with multiple stays during a 12-month time window, each stay is eligible for inclusion in the measure. So you may have one patient, okay, who may be included multiple times in a particular quarter based on this criteria. So items from the admission assessment used to risk adjust this quality measure. So risk adjustments are important. Functional mobility admission performance. So looking at GG 0170C, the mobility, and which we'll be looking at specifically the lying to sitting on the side of the bed. So that item is used. Bowel continence is used. So that it's H0 400. So that's a risk adjuster also. Peripheral vascular disease, peripheral arterial disease, or diabetes are included. So those are I0900 and I2900, which is diabetes. So that makes sense, right? That can impact pressure-related issues. And then low body mass index, and that is calculated based on looking at the height and weight. All right, so that is K0200A and K0200B. So those are all your risk adjusters. So why do I even bother telling you about them? Because you want to make sure that not only, first off, you should make sure every item in this set is accurate. But when we're trying to look at this from a quality perspective, if we're looking at our numerators and our denominators, those that are falling in, are we first coding them correctly as having a pressure ulcer or not? And then two, are we also making sure that all these risk adjusters are accurately coded? So again, ensuring that we have an actual height on a person. Have we estimated? Have we actually measured the person? Do we have a recent weight on the person? So all of these things matter. And did we capture bowel continence and whatnot? All right. So let's look just quickly on some of the changes between version 3.0 and 4.0 of the data set. So CMS is aware of the array of terms used to describe alteration in the skin integrity due to pressure. And they've evolved over the years from pressure ulcers to pressure injuries to pressure sores to decubiti to bed sores. I mean, these are all words to describe a pressure-related injury to skin. So that being said, it's acceptable to code a pressure-related skin condition in Section M if different terminology is recorded in the clinical record. So just because someone calls it a decubitus ulcer or a bed sore, as long as it meets all the other criteria, and in fact is a pressure-related ulcer, then you could go ahead and still code this. It doesn't have to say pressure injury or pressure ulcer. So we kind of, now we've said CMS is aware of all these different terms, but now we're going to define some of them. So throughout the LTCH CARE Data Set and QRP manual for this training, CMS adheres to the following guidelines. So a stage 1 pressure injury and deep tissue injuries are termed pressure injuries because they are closed wounds. So this is how CMS is saying it, okay? So when we're talking about a deep tissue injury where the skin is intact, or like a stage 1, we're gonna call those pressure injuries. When we start to get into the stage 2s, 3s, and 4s, the pressure ulcers or unstageable ulcers due to slough and eschar, they're gonna term these as pressure ulcers because they are usually open wounds. So we have an injury where the skin is still closed, and then we have an ulcer where the skin so it's an open wound. Unstageable ulcer injuries or / injuries due to non-removable dressing or devices are termed pressure ulcer / injuries because they may not be open, they may be open or they may be closed, but we don't know because we haven't been able to take the device off or the dressing off or whatever it is to assess them. Does everyone understand So these are just important terms to know. They're minor, but you want to make sure that whoever is completing the data set understands the different verbiage and what it means in these manuals. So this is just a picture of the item set, and I'm sure all of you can read. This is a real test for how your eyesight is. It's teeny tiny. We were hoping to be able to do a blowout, but basically the words in yellow, because that's the most important word, is where the change is. And what it just says is it said reporting based on the highest stage of existing ulcers / injuries. So you'll see that throughout the item set, that word injury has been added to the items. So it did not change significantly. So the term device was added to the item M0300D1 through M0300E and then M0300E2 in the admission and the planned discharge and unplanned discharge assessment, effective July 1, 2018. So basically what it says here is the number of unstageable pressure ulcers / injuries due to non-removable dressing / devices. And it's just taking it into consideration, and I think a lot of this came from actual, feedback that the industry has given CMS to say not everything's a dressing. It could be a type of splint, it could be a cast, it could be something else. That's not considered what we would consider a dressing, like a primary surgical dressing. So it was just saying it could be a device and or a dressing. They removed the term suspected deep tissue injury in evolution and they replaced the term with deep tissue injury to items M0300G and M0300G1 in the admission, planned discharge, and unplanned discharge assessments effective July 1st, 2018. So instead of that suspected deep tissue injury, we're to deep tissue injury will be the terminology. And again, it's highlighted in yellow on the screen, and this is a screenshot. One of probably the biggest changes in this particular section is M0800A through M0800F, worsening in pressure ulcer / injury status since admission. These items have been removed from the planned discharge and the unplanned discharge assessment. So they're gone from the assessments. All right, so now what we're going to go through is looking at the various skin conditions and coding guidance and coding scenarios. And hopefully we're going to go through quite a few of them. And some of them were based on direct questions that were asked, some areas of confusion in previous trainings. So hopefully this will just clarify it. And what I would encourage you to do is you don't have the answers in your sheets. I do. But we will post on the site, the CMS website, the slides with the answers in here. And what you can do is use these for some training scenarios with your staff. So these are, ready-made training materials that you can use with your own staff to ensure that, one, at least they would know how to apply the coding methodology. It wouldn't ensure that they understood how to code an ulcer by looking at it and looking and assessing the patient, but at least will help with the coding side of things. So what we're looking at here at M0300 is current number of unhealed pressure ulcers or injuries. So at admission, we're looking at M0300A1 through G1, and it identifies the number of unhealed pressure ulcers or injuries at each stage and establishes the patient's baseline assessment. So this starts kind of the clock for you. So how quickly should we gather this information? It should be gathered as soon as you can get it, as close to admission. So I don't know, people may have their own facility or organizational policies or procedure that says a skin assessment must be done within fill in the blank hours of admission. Certainly you want to follow that. But we don't really want to be doing skin assessments day 2, right? A lot can happen even in the first 24 or even the first 12 hours of someone being in your organization. So you want to try to get that done as soon as possible. The discharge assessment, planned and unplanned, looks at M0300A1 through G1 and it identifies the number of unhealed pressure ulcer or injuries at each stage. And then it says, of those that are there at discharge, it asks the next question, M0300A2 through G2, and it says, okay, at the time of discharge, it identifies if the unhealed pressure ulcer injury in M0300A1 through G1 were present on admission, or if the pressure ulcer injuries were acquired or worsened during the stay. That's what that question is asking. We're going to give you lots of examples on how to do that. So it's a subset. So if I said I had a stage 2 pressure ulcer on admission on my, on my coccyx, and then on discharge, I still had that same stage 2 pressure ulcer. So it'd say, yes, I still have one, right? I still have a stage 2 pressure ulcer. And then it would say, how many of this above stage 2 pressure ulcers at discharge were there on admission? And I would say, well, I only had the one, and it was there on admission. So I would say it was there upon admission. So steps for completing M0300A through G. Well, we certainly want to determine the deepest anatomical stage of the wounds. We want to identify unstageable pressure ulcers or injuries. And for the discharge assessments, we want to determine the number of ulcer injuries that were present upon admission. This is just a screenshot. So I'm sure you all can read that in the back of the room, and I'm sure you at home. I'm not sure how clear this will be because I'm sure it's very small, but this is just a screenshot of the item set. So M0300A1 through G1, the coding instructions are complete only if 0250 equals an admission assessment, a planned discharge, or an unplanned discharge. Those are the only times that we're doing these questions. And we want to enter the number of pressure ulcers that were currently present and enter 0 if no pressure ulcers are present. Here we have M0300, current number of unhealed pressure ulcers or injuries at each stage at discharge. And then this actually, we couldn't fit on one screenshot. And this just is continuation of what you would see on your form. It would all be together, but we had to split it into two sections. So M300B2 through G2, we're going to complete only again if this is a planned discharge or an unplanned discharge, right? Because this is done only, these items are only done at discharge. We want to enter the number of pressure ulcers or injuries that were present on admission. And you could go back to looking at M4 under steps for completing M0300A through G. And then step 3 is to determine present on admission. And then enter 0 if no pressure ulcer injuries were noted at the time of admission. And again, don't worry about this. We're going to go through lots of examples, and I think this will be very clear for you at the end. So the present on admission items are coded at discharge. So we want to know what was there upon admission. And it addresses whether the pressure ulcer or injury observed at discharges were 1, present on admission, and if they weren't, so if I have an ulcer, was it there, and was it there at the same stage at admission? If not, it's saying it was acquired or worsened during the stay. That's really what it means if it wasn't there upon admission. That's what this area is looking at. Hence, we could get rid of that other whole set of questions that we had. The pressure ulcer injury reported at discharge and coded as not present on admission on the discharge assessment would be interpreted as a new or worsened ulcer. That's what it's telling us. The pressure ulcer or injury reported at discharge and coded as present upon admission on the discharge assessment would not be considered a new or worsened pressure ulcer. So if it was there and there at the same stage, it wouldn't be indicated as present on admission. All right, so we're going to just start going through some coding scenarios. These first couple of ones we're just going to do together, and then I'll go through a scenario and give you some time, a minute or two, to complete what you would say would be the coding on that, and then we're going to come back together as a group and we'll code them. So here's our first scenario. A patient is admitted to the LTAC with a stage 2 pressure ulcer on the right hip. At the time of discharge, there is no change in the stage 2 on the right hip. Additionally, there is a new stage 2 pressure ulcer on the right heel. So they came in with a right hip. By discharge, that right hip ulcer is still a stage 2, but oh, by the way, they have a new stage 2 pressure ulcer on the right heel. So in this scenario, we've already completed the coding, but let's talk it through. So here we have the first question, M0300B1, the number of stage 2 pressure ulcers, and there's 2 columns there, right? There's admission and discharge. And in the admission assessment, we're coding as 1. And we said 1 because what? They had 1 stage 2 pressure ulcer on their hip. And then the discharge assessment, how many stage 2 pressure ulcers did they have? They had 2, right? They had 1 on the hip and 1 on the heel. Then the next question says, M0300B2, the number of these stage 2 pressure ulcers that were present upon admission. So now, right, 1. And what it's saying here is, on the discharge, we had 2, but of those 2, 1 was there present upon admission, but 1 is new. And that's where that coding a 1 comes in under new. That makes sense? Okay. And here's just the rationale. And again, you're going to have, the nice thing is you'll have all of this information that you can use for training when you go back to your organizations. So upon admission, the patient had a stage 2 pressure ulcer on the right hip, and we coded that. And then upon discharge, the stage 2 pressure ulcer on the right hip was the same. And so we coded the M0300B1 as having the 2, and we have M0300B2 coded as 1 because they had the 2 ulcers. The 1 on the hip was there on admission, and of course the heel, which was developed. So let's just pause for a second and talk about pressure ulcer and program interruption. There was a lot of kind of questions in the past around this. If a patient is transferred from your long-term care hospital and returns within 3 days, including the day of transfer, the transfer is considered a program interruption, which you all know, and is not considered a new admission, right? So if they go out and they come back within that 3 days, including the day of transfer. Therefore, any new pressure ulcer or injury formation and or an increase in the numerical staging that occurs during the program interruption should not be coded as present upon admission. So what does that mean for you? It will show up as new or worsening, right? Even though it's a program interruption. I know that's probably a very bitter pill to swallow, but it is the coding on that. The only time that this would be considered new would be if it wasn't a program interruption, right? They were gone 4 or 5 days, and then what is it considered? A new admission, right? And then you would go through the whole process again.
But there are some program interruptions that can last up to 45 days.
So can you hold that question for the end, and we'll talk about that? Okay. All right. So let's go through another coding scenario. A patient is admitted to your LTAC with the stage 2 pressure ulcer on the left hip. The patient is transported to the acute care hospital and returns to the LTAC within 2 days. Upon return to the LTAC, the left hip pressure ulcer is a full thickness ulcer assessed to be a stage 3. The patient is discharged to home with a stage 3 pressure ulcer. So think about how we'd code that one. So we're starting with the stage 2 pressure ulcers, 300B1 there. The number of stage 2 pressure ulcers on admission was 1, right? And then the discharge assessment, the number of stage 2 pressure ulcers present at discharge went to 0, right? Because that stage 2 progressed to a stage 3. So at discharge, they didn't have any stage 2 pressure ulcers. Everyone agree with that? I'm seeing some kind of not sure. Okay. Then we're looking at, so then M0300B2, the number of these stage 2 pressure ulcers that were present upon admission is a skip. And it's a skip because we don't have any showing on the discharge assessment. So if it's a 0, the next item underneath it will be a skip, because it's saying of the ones that are present at discharge at that particular stage, how many were present upon admission. So since I don't have any stage 2s right now on discharge, I'm going to skip that next question. If you had this in a program in your computer, it would automatically skip you out of this. The number of stage 3 pressure ulcers coded at admission, patient didn't have any, right? They had a stage 2. Now at discharge, we know that they have one, that stage 2 now progressed to a stage 3. So they have one stage 3 pressure ulcer upon discharge. The next question, M0300C2, says the number of these stage 3 pressure ulcers that were present upon admission. And that answer is 0. Why? Because the only thing we had on admission for this particular patient was one stage 2 pressure ulcer. So on the back end, what this is telling you, if you were looking at this assessment, but what it's going to tell when they do the analysis is this patient had a new or worsened pressure ulcer, even though it happened during a interruption of stay, because they did not have an actual discharge assessment done and a new admission being done. Okay. So we kind of talked through this already, the rationale here. So they had that stage 2 on the left hip, and that's the reason we coded that 1 on admission. They went to the acute care hospital. It came back. It was a stage 3. And so since no new admission assessment is required, the change in the pressure ulcer status is captured on the discharge assessment as new or worsened. And so this is what we ended up coding, this particular patient. So let's talk a little bit about unstageable pressure ulcers or injuries. So when you're going to code unstageable pressure ulcers or injuries, visual inspection of the wound bed is necessary for accurate staging. That's really important, right? You need to be able to look or to see enough of the wound bed to understand, are you seeing the deepest part of that wound bed, especially if it's covered with slough or eschar. So if they have eschar or slough tissue present such that the anatomical depth of the soft tissue damage cannot be visually inspected or palpated in the wound bed, it should be classified as unstageable. So let's give you a couple of scenarios. So if I'm looking at a wound and I've got, let's say, half to 3/4 of it covered with eschar or slough, but I see bone or tendon, can I stage that ulcer? Yes, I can. It'd be a stage 4. It's very clear what that is. Once you see that, you know it's a stage 4. It doesn't matter if I clear out the rest of it. I can already see it's down to that deepest stage. But if you can't see enough of the wound bed to understand that you're looking at the deepest part of it, and the majority of that wound is covered with slough or eschar, or if it's all covered, then you have to code that as unstageable. Okay. If the wound bed is only partially covered by eschar or slough and the extended soft tissue damage can be visualized, which I just talked about, and so that means you can confidently numerically stage it, then please don't code it as unstageable, but go ahead and stage that wound. I think I didn't really talk a lot about it here. I think the biggest opportunity for clinicians who are not specifically trained in wound care, so your average kind of RN out there who's looking at wounds, besides understanding what's pressure and what's not pressure, once they realize that it is pressure, is being able to identify and differentiate between a stage 2 and a stage 3. So if there's any kind of slough in the wound and someone wants to code it as a stage 2, so sometimes you'll see someone stage something as a stage 2 and then describe the slough on it. A stage 2 can't have slough. So that's another opportunity when you're working with your staff and you have the opportunity to give them a variety of different scenarios. That's always one I like to throw in there because you want to make sure that they understand that if it has slough, it's automatically, minimally at that point, a stage 3. All right, let's do another coding scenario. So a patient is admitted to the LTAC with eschar tissue identified on both the right and the left heels, as well as a stage 2 pressure ulcer on the coccyx. So they have 3 ulcers. The patient's pressure ulcers are reassessed before discharge, and the stage 2 on the coccyx pressure ulcer has healed. The left heel eschar became fluctuant, showed signs of infection, and had to be debrided at the bedside, and then was subsequently numerically staged as a stage 4 pressure ulcer. And the right heel eschar remains stable and dry, i.e. it remains unstageable. And now we're going to look at how we would code this particular scenario. So here we have the number of stage 2 pressure ulcers. We code it as a 1 on admission and 0 at discharge. And then we would do a skip for the next one because it asks us of the above, of the number of stage 2 pressure ulcers at discharge, how many were present upon admission. Since I had 0, I skipped that. M0300 C1, the number of stage 3 pressure ulcers, we coded that as a 0 on admission. And we had 0 at discharge, so we skipped then the next question of M0300 C2. Then we get down to stage 4. So we have M0300 D1, number of stage 4 pressure ulcers present on admission. We didn't have any stage 4s present upon admission, but at discharge we do, right? That heel, once that was debrided, we ended up having a stage 4. The number of these stage 4 pressure ulcers that were present upon admission, and the code here is 1. It wasn't present upon admission. Then we go on, this series of questions here. M0300E1, the number of unstageable pressure ulcer injuries due to non-removable dressing. Well, we didn't have any that were unstageable from dressings or devices, so we would code 0 at admission and 0 at discharge, and then we would skip the next question of M0300E2. Then we have M0300F1 that says the number of unstageable pressure ulcers due to slough or eschar. And we would code that as 2 of those because those were both the heels that we had. They were both unstageable when the person was admitted. And then upon discharge, one heel still had an intact eschar on it. So we had 1 unstageable on one of the heels. And then the number of these unstageable pressure ulcers due to slough or eschar that were present upon admission. So that one heel that didn't progress, that didn't need debridement, was there on admission and it was there at discharge and it was stable. So we'd code that one as a 1. And so the rationale here, we went through this. We had the coccyx was present upon admission and then healed, so it wasn't there on discharge. And then we talked about the left heel being debrided and now become a stage 4, and the right heel having the eschar that remained intact. So in fact, we had one of those on discharge and it was present upon admission. So non-removable dressing or devices. Known pressure ulcers or injuries covered by a non-removable dressing/device should be coded as unstageable. So there's a word in here that's important. It's known. So we would code this only if we had communication or documentation as they were coming in that said, geez, they have this cast or whatever, and we had this pressure ulcer, we had to cover it. It's got a dressing that we can't remove or whatever it is. But we know that we have something under there. And so it's known to you. So for an example, it includes a primary surgical dressing that cannot be removed per physician orders or an orthopedic device or cast, but they're telling you there was this pressure ulcer underneath it or injury. Known refers to when documentation is available that says the pressure ulcer or injury exists under the non-removable dressing or device. So that has come up frequently as a question. So it's the idea that you have to know about it, not that you didn't know about it and then you take the dressing off or the cast off and then all of a sudden they have these injuries, but they came into you and you didn't know about them. All right, so what I'd like you to do, we're going to start to go into some of the coding scenarios where we're going to have you start to practice. And for those of you who are on live streaming, if you want to pull your coding scenario document out, if you didn't get a chance to print it or whatever and you want to just use scrap paper, you can do that in your office or wherever you're watching this. So we're going to talk about coding scenario 4. That's the first one that we're going to do. I have it up here on the screen and we're going to talk about it, but if you look at your coding sheets, the scenarios for each one of our coding scenarios is right on top also, so that you can reference it right at your tables. So coding scenario 4. So a patient is admitted with documentation in the medical record of a sacral pressure ulcer or injury. This ulcer or injury is covered with a non-removable dressing, and therefore the pressure ulcer injury is unstageable. On day 5 of the stay, the dressing is removed by the physician, and assessment reveals a stage 3 pressure ulcer. On day 10 of the stay, the pressure ulcer is covered with eschar and is assessed as unstageable. The eschar covered ulcer is unchanged at the time of discharge. So I want you to just take a moment, if you will, and answer the assessment on the first page of you can, where it says coding scenario 4. And again, the coding scenario is right on top. I'll give you just a moment, and then we'll review the scenario. Okay, we ready? Okay, so let's go through this scenario. So M0300E1, the number of unstageable pressure ulcers due to non-removable dressing or device. What do we have for the admission assessment? 1, everyone agree on 1? Okay, good. How about on the discharge assessment? 0? Correct. So if we have M0300E1 discharge being a 0, how would we answer M0300E2, the number of these pressure ulcers or injuries due to non-removable dressings that were present upon admission? We're going to skip it. Exactly. It's a skip pattern because we didn't have any at discharge. So the next question, M0300F1, the number of unstageable pressure ulcers due to slough and or eschar on admission. Do we have any of those? No, 0? Okay, correct. Same question, but at discharge. Do we have any? We have 1, correct. So now the question M0300F2, the number of these unstageable pressure ulcers due to slough or eschar that were present upon admission. Okay, so have some people saying 1. Anyone else? Some people saying 0. And so the answer is 0. In fact, we didn't have any of these ulcers that were unstageable due to slough or eschar on admission. So where we had that 1, none of that 1 was present upon admission, so you would code that as a 0. And we'll just go through the rationale here. So the documentation that accompanied the patient on admission identified a pressure ulcer that was located beneath a non-removable dressing. This known ulcer, this known ulcer injury is coded as a 1 on the admission assessment as unstageable pressure ulcer or injury due to non-removable dressing or device. And then once we removed the dressing, the physician staged the ulcer as a stage 3 pressure ulcer. And at the time of discharge, that then progressed the point that it was covered with slough or eschar, so it couldn't be staged. So that's the reason the unstageable pressure ulcer, which is M0300F1, due to slough or eschar is coded as a 1, and then F2 is coded as 0 because the pressure ulcer was not unstageable due to slough or eschar on admission, okay? It was unstageable due to a non-removable dressing or device, but not because of eschar. So just subtleties within the questions. So healed pressure ulcers or injury, the terminology referring to healed versus unhealed ulcers or injuries refers to whether the ulcer or injury is closed versus opened. So a stage wound pressure ulcer and a deep tissue injury are unstageable pressure ulcers, although covered with tissue, eschar, or slough would not be considered healed. And of course, we know, for those of you that are clinicians, that that term healed is a really complex terminology, because once we have damaged the skin with a pressure ulcer that's full thickness, that as it heals or closes, sometimes you can end up with a primary epithelialization. That was a tough word for me to say. Closed on top, but in fact, the scar tissue and the other tissue underneath it hasn't filled in. And we know that once we have that, the tensile strength of that tissue is about 80%. So it's always kind of at risk anyway, so it's never going to be as strong as the skin that we were born with, okay? So we know that someone could be at risk with that. All right, so let's go to coding scenario 5 in your little coding sheet here, and we'll go through a different scenario. So here we have a patient is admitted to the long-term care hospital with a bruised, butterfly-shaped area on the sacrum and a blood-filled blister on the right heel. The sacral area, based on assessment of the surrounding tissue, is determined to be a deep tissue injury. The heel blister is also assessed, and based on the assessment of the surrounding tissue, it is determined that the heel blister is also a deep tissue injury. 4 days after admission, the right heel blister is drained and conservatively debrided at the bedside. After the debridement, the right heel is staged as a stage 3 pressure ulcer. On discharge, the right heel remains at a stage 3, and the sacral area continues to be assessed as a deep tissue injury at discharge. So, you've got the scenario on the top of your sheets. I'm going to give you a minute or so to go ahead. There's more questions to answer here, but go ahead and complete it. Now, there's 2 pages of answers, right? So there's the first page with the scenario on it. Flip it over, and then you have continued to answer all of these questions in this assessment. And for those doing live streaming, I ask you to do the same thing. Okay, let's go through the coding together on this with this patient. So you can keep the scenario in front of you. So with this particular patient, M0300B1, the number stage 2 pressure ulcers on admission. Any stage 2s? So we'd put a 0 there, right? Okay. How about stage 2s at discharge? Okay, they didn't have any, 0, correct. Okay, how about M0300B2, the number of the stage 2 pressure ulcers that were present upon admission? Skip, very good. You guys got this down pat. Okay. How about M0300C1, the number of stage 3 pressure ulcers on admission? Okay, they didn't have any, 0. And then how about number of stage 3 pressure ulcers at discharge? Right, they had 1. The number of these stage 3 pressure ulcers that were present upon admission? We're going to go through the rationale. Okay. Number of stage 4 pressure ulcers? Right. The number on the discharge assessment? Right. And the number of these that were present upon admission? Skip, right? How about the number of unstageable pressure ulcers due to non-removable dressing? Right? How about at the discharge assessment? Do we have any of them for non-removable dressing? No. How about the number of the unstageable pressure ulcers due to non-removable dressing that were present upon admission? We're going to skip that, right? Because they had 0 ahead of it. How about number of unstageable pressure ulcers due to slough or eschar on admission? Okay. How about at discharge? Okay. So then we'll skip the next question, right? Because we didn't have any. The number of unstageable pressure injuries with the number of unstable pressure injuries with deep tissue injury. 2. And then how about at discharge? Right, we had 1 left, right? So then we asked the question, number of these unstageable pressure ulcers with deep tissue injuries present upon, for the discharge assessment that were present upon admission. Right, we had 1. Okay. So let's go through the rationale on how we coded these particular questions. I'm just going to flip forward in my notes. Oops. All right. So after thorough clinical and skin examination, as well as an assessment of the lesions and surrounding tissue, the sacral and the heel areas were determined to be consistent with what is constituting a deep tissue injury, right? So you assessed it and you said, this is what we're dealing with, deep tissue injury. For the admission assessment, M0300G1 is coded as 2 because there were 2 deep tissue injuries, both present upon admission. So we agree about that, right? Once the heel deep tissue injury is drained, debrided, and numerically staged, so M0300C1 and C2 are coded as 1 on the discharge assessment. M0300C1 is coded as 1 on the discharge assessment because the heel deep tissue injury was debrided and was able to be numerically staged. Because this was the first time that you were able to assess and numerically stage it, it is considered to be present upon admission. So they came in, so I see some confusion. So they came into, you knew you had a deep tissue injury. You just didn't know what it was when it really declared itself, right? When you got a sense to either if it had dried up, let's say that blood had dried up and ended up with eschar, sometimes that cap will come off and then you get to look underneath and see what it is. Sometimes it may get infected and gets debrided here for whatever reason. They chose to drain it. But now it's for the first time we get to look at the bed of that wound. And we know under that blood-filled blister, once that was all cleaned out, the physician is telling us it's a stage 3. So nothing happened to make that worse. There was something there, we just didn't know what it was. So the first time that we can numerically stage it, we then say that that was present upon admission because that injury was already happened. Does that make sense to everyone? Okay, upon admission. So we identified it was there, we just didn't know what it was. M0300G1 is coded as 1 at the discharge assessment because the sacral deep tissue injury cannot be numerically staged. And 300G2 is coded as 1 at the discharge assessment because of the 2 deep tissue injuries that were present on admission, only 1 remains as a deep tissue injury, right? Because the other one ended up being a stage 3, right? Because we were able to say, we now know that it's a stage 3. All right. That was scenario 5. Let's flip to our coding scenarios here. And let's go to coding scenario 6. This should be a quick one for you to do. Not a lot of questions. So coding scenario 6. The patient's skin assessment on admission reveals no pressure ulcers or injuries. On day 5, the patient record identifies a stage 2 pressure ulcer on the right elbow. On discharge, the patient's skin assessment reveals a healed stage 2 pressure ulcer on the right elbow. So let's go ahead and do coding scenario 6 on your papers. Everyone got that one done? That was quick. Yes? Being around? Okay. So now we're looking at M0210, unhealed pressure ulcers. Do we have any unhealed pressure ulcers at admission? So we'd code 0, right? Right? Do we have any unhealed pressure ulcer or injuries at discharge? 0, right. So here we have the rationale. The patient had no pressure ulcer injuries on admission, although the patient developed a stage 2 pressure ulcer on their elbow on day 5. That pressure ulcer healed, or closed as we are calling it, at discharge. Therefore, M0210 would be coded as 0, and all of M0300 pressure ulcer injury items would be skipped, right? So if we were doing this on a computer, this would skip us out because we wouldn't have any pressure ulcers to then ask all those other questions about. So they actually did have a pressure ulcer while you cared for them, but they got it after admission and you healed it before they were discharged. So it's not accounted for in this assessment. Does that make sense? Okay. So medical devices related pressure ulcer. So when a pressure ulcer is caused due to the use of a medical device, you need to assess the area to determine if the pressure is the primary cause. Again, remember, it's not a pressure ulcer unless I can remove pressure from the area of the wound to help heal it. And so you have to determine whether pressure is a primary cause. These ulcers or injuries generally conform to the pattern or shape of the device. And so ones that we've seen can be from braces, and we're actually going to do an example around that. It could be in a seating. I've seen people develop pressure ulcers from how they're seated in a wheelchair, and their leg rests against a part of the wheelchair, and they're just not repositioned. And you know, depending on someone's circulation and all of those other things that put them at higher risk, and all of a sudden, you can, if you put them back in the chair, you can match that area of the chair to the wound that they have. And often you'll see staff do that, saying, I had to figure out, obviously I need to remove the pressure, so I need to figure out what was putting the pressure on. So if you're a good kind of detective and you look for these things, you can find them. If pressure is determined to be the primary cause, use the staging system to stage the ulcer or the injury, and code in section M of the LTCH CARE Data Set. If the ulcer injury is not due to pressure, do not code in section M. So this just goes back to everything I've already said. Make sure that you're only coding pressure ulcers here. Don't take credit for everything else. And inevitably, that's what I see. Stasis ulcers coded here. Again, arterial ulcers, other things. Now that doesn't mean that you can have peripheral arterial disease or peripheral vascular disease and still have pressure and still end up with a pressure injury. The other one that tends to get staff a little bit are diabetic ulcers. So making sure that you understand whether there's pressure involved with that, depending on where the ulcer is. Is it a diabetic ulcer, or are we looking at a pressure ulcer? That doesn't mean that diabetics don't get pressure ulcers. It's just a matter of you have to use your clinical judgment to make an assessment on that. And if you're not the person that has all those skills, within your organization, I'm sure there's someone who is considered the expert in that, and you want to bring that person in. Some of them, staff will get very comfortable with the everyday type of things, and then they're going to look at something and they're going to go, I'm not sure what I'm looking at. And so that's your opportunity to bring someone in who has maybe greater expertise in a particular area and have them take a look at it and help you to decide whether it's a pressure-related injury or not. So we have another scenario, coding scenario 7. So if you pull out your forms, and we're going to do another coding scenario. So here we have one that's device-related. So a patient is admitted with a right ankle foot orthosis, an AFO, to compensate for weakness and foot drop. On the initial skin assessment, the clinician notes a stage 2 pressure ulcer at the right calf, and this conforms with the shape of the AFO. I can't say that word, is consulted, like one of those things, is consulted and the AFO is adjusted. So they brought someone in, they had looked at the brace and they made some adjustments to it. The ulcer heals before discharge and no other pressure ulcer injuries are present. So let's go ahead and answer the questions in scenario 7. Okay, let's go through the staging on the coding on this. So we're starting in a slightly different spot here for this set of questions. So M0210. So this is part of our admission assessment. Is there an unhealed pressure ulcer or injury? Yes. Okay, so we're saying yes, there's something there. Okay, how about at discharge? Right, so we're coding that as a 0, right? There's nothing at discharge. M0300B1, number of stage 2 pressure ulcers on admission. Right, had 1. And then how about number of stage 2 pressure ulcers at discharge? 0, right. It actually should be a 0, not a skip. And then M0300B2, the number of these stage 2 pressure ulcers that were present upon admission. No, so skip. So we're saying that the number of stage 2 pressure ulcers at discharge was 0, right? And it was 0 because what? It healed, right? It healed. So at discharge, I don't have any stage. So they came in with a stage 2 right by, and actually we're going to go, I should probably go to the rationale because it will take us through all of this. So the patient came in and we identified that they had a stage 2 and in the calf by the AFO, okay? So they determined it matched the shape and the size that it actually was a pressure ulcer caused by the AFO. So they had that and they staged it as a stage 2. They actually got someone in to make adjustments to it, right? We certainly want to do that because we got to relieve pressure to help heal or allow progression of a pressure ulcer. And then, so here again, just following the instructions of the purpose of coding, a determination was made that the lesion being assessed is primarily related to pressure. So it wasn't any kind of other vascular ulcer or anything else. We said, put the splint on, put the AFO on, here it matches perfectly, it even has the shape and the size. So we call in someone and we have an adjustment made to it. So we knew that they had at least one stage 2 pressure ulcer on admission. And then the stage 2 pressure ulcer is healed at the time of discharge, and there were no other pressure ulcers. So the number of pressure ulcers at discharge are 0, and we have then we have, when you look at the number of these stage 2 pressure ulcers that were present upon admission, would be a skip. So if we don't have any, remember that whole coding pattern? If I don't have any, if I'm saying if I don't have any stage 2 or at discharge, I don't have any stage 3, we're unable to say how many of those were present, right? Because it's asking at discharge, of the ones that we have at discharge, how many of them were present upon admission? Does everyone get that piece of it? Yeah? Okay, because that's an important piece. Because because I saw people saying, well, wait a minute, they did have a stage 2 on admission, and that's true, but at discharge they didn't have any. And then that follow-up question is asking just about the ones left at discharge, how many of those were present upon admission? And that's where we're skipping and saying that there's none. So let's talk about other types of ulcers, mucosal ulcers. So mucosal pressure ulcers are not staged using the skin pressure ulcer or injury staging system because the anatomical tissue comparisons cannot be made. They're different tissue type. Therefore, mucosal ulcers, for example, those related to nasogastric tubes, oxygen tubing, endotracheal tubes, urinary catheters, mucosal ulcers in the oral cavity should not be coded as pressure ulcers on the long-term care data set. Does that make sense? Now that doesn't mean that you can't get a pressure ulcer from oxygen behind the ear. Because that mucosal? No. So that's not what this is saying. It's really looking at what would be, in the nasal area if you were doing a pronged, a nasal cannula, or the nasogastric tubes and whatnot. So, so they can't be staged. Does that mean that we ignore them clinically? No, of course. We're still going to, be ever vigilant, very aware, try to prevent any kind of skin injuries where we can, and then certainly treat and care for and plan for any kind of injury that may occur. All right. So coding scenario 8. I told you we're going to do a lot of coding. This is our last kind of practice scenario. So if you pull that up on your sheet. So in this scenario, a patient with a gastrotomy tube or a G-tube is admitted to your organization. The G-tube insertion site is covered with a dressing. The admitting clinician removes the dressing to complete an admission skin assessment and identifies a lesion present at the stoma. There are no other lesions identified at admission and throughout the stay. So here's the question. So just if you could quickly answer those questions, we'll talk those through then. Okay? It's an easy one for people? Okay. So we're looking at M0210, unhealed pressure ulcers. Do we have any unhealed pressure ulcers at admission? Right. So we're going to code that as a 0. Correct. None. And then the same question, do we have any unhealed pressure ulcers or injuries at discharge? No. 0. Right. The lesion is present at the gastrotomy stoma. The stoma mucosa is not staged using the pressure ulcer system, which we just talked about. But think about your own staff. Do you think they might code something like this? I've seen it staged. I've seen it staged. So when we continue towards the end, I think we're going to end up having a little bit of time. We may want to take some opportunity when I finish up my program today of this section. This is a section I think there's lots of great opportunities to write some ideas down into your action plan about, let me check on this, let me check on that, let me check with my educator if you're not the educator, let me go back and ensure that all of the staff who may be staging anything really are competent in being able to understand what they should stage, what they shouldn't stage, and if they are going to stage something as a pressure ulcer, let's say they assess it and they determine that it's a pressure ulcer, am I really confident that they can stage it at then the appropriate stage? So this lesion, so the mucosal pressure ulcers are not staged using the skin pressure ulcer staging system because that tissue is different. We just talked about that. So those related to NG tubes and all the other things that we talked about wouldn't be covered in this particular area. So let's take an opportunity to talk about the Kennedy ulcers. And this caused some confusion the last time that we taught on this. So the Kennedy ulcer is a skin ulcer that occurs at the end of life and are known, of course, most of us call them a Kennedy or a terminal ulcer. Kennedy or terminal skin ulcers are not captured in Section M of the long-term care data set. However, they should be assessed and staged using pressure ulcer injury staging system, documented in your clinical record and addressed in your care plan and whatever else you're going to do for that person. So we're saying clinically, don't ignore them. We're just saying don't identify Kennedy ulcers on the data set. The etiology is believed to be related to tissue perfusion issues due to organ or skin failure, right? One of our biggest organs is our skin. And so in part of the dying process, the perfusion, everything is shunting away and just trying to get to the brain and the heart and the kidneys and the liver and trying to keep all of our vital organs. And so we start to see the perfusion of the skin decrease. And the evolution and appearance differ from a typical pressure ulcer. So the reason for not capturing it here is it's not going to follow the pathway of a normal pressure ulcer. And so we want to make sure that staff could identify what they look like. Generally, a Kennedy ulcer can appear from 6 weeks to 2 to 3 days, or even within 24 hours of someone's death. For many people, especially the very classic Kennedy ulcer, happens around the coccyx area, and it can be a pear or butterfly shape. I think once you've seen one in your life, you'll never forget one and what it looks like. So just know it's there. Please don't ignore it. Please plan for it. Do everything else you need to do. Just don't put it on the care set. Okay. So we're just going to go through a couple of quick other scenarios, but we're not going to have you write anything. We'll do these together. So a patient is admitted to your LTAC with one large stage 3 pressure ulcer on their coccyx. At the time of discharge, there is some epithelialization in the center of the pressure ulcer. So let's think about how we would code this one. So the first question is the number of stage 2 pressure ulcers present upon admission. 0, right? The number of stage 2 pressure ulcers on discharge. 0, right? Then we would skip, remember that skip pattern, all right? The number of stage 3 pressure ulcers present upon admission. We had that 1, right, that we talked about. And then at discharge, we still had the 1. Starting to heal though, which is great. But it was still stage 3. And then it's asking the number of the stage 3 pressure ulcers that were present upon admission. 1. That same ulcer that was there at admission, there at discharge, although it looks like it started in the healing process. So it was, and then it was present upon admission, which is exactly what we have here in our coding scenario. All right, let's go through. So here's another quick scenario. A pressure ulcer described as a stage 2 on the heel was noted and documented in the patient's medical record upon admission. On discharge, this wound is noted to be a full thickness ulcer, thus is now a stage 3 pressure ulcer in the same location. Not an uncommon thing that happens, especially in heels. So if you were coding this, think about your coding. So here we have number of stage 2 pressure ulcers. What did they have on that heel? They had a stage 2, right? They had a stage 2 on the heel when they were admitted. So we're going to code as 1. At discharge, did they have any stage 2s? No. Okay, the number of stage 3s on admission? 0, right? They didn't have any on admission. They only had a stage 2. That same heel now progressed, and so now at discharge they have 1. They have stage 3, and they have 1 of those. And then we ask the question, of that stage 3 that we have on our on discharge, how many of those were on admission? 0, right? We didn't have any on admission. And if you start to look at the patterns on these, it really is very telling. If I didn't have any on admission, and now I have some on discharge, none of these were present upon admission. You almost know the answer is going to be 0. Now, have you ever seen a patient with like 7 pressure ulcers? Yeah, I have over the years. So sometimes this can get pretty complex. You may have someone with all kinds of things going on. So you want to kind of write it all out and know exactly your count on each one of these. What was available, what was there on admission, and now what do I have at discharge? So this is the rationale. We just went through that. Because we didn't have the stage 2, it progressed to a stage 3, we skipped it. This just goes on to the rest of the scenario. We put those instructions in there so that, again, we think that not only in just reviewing it here today, hopefully you'll take this information back. But you'll have the blank ones that are out there now, but then you'll also have the answers, and you can use that for teaching. So in summary, and I'm going to be ahead of schedule, but we're going to kind of talk through what we're going to do there. To be inclusive of updated terminology supported by NPUAP, the National Pressure Ulcer Association, the term injuries has been added to Section M headings in the following items, and we went through all of those. So we've added that word injury to be updated. We've also removed the term, CMS has removed the term suspected deep tissue injury and replaced it with the term deep tissue injury. And then to improve clarity, the term device was added to M0300A, E, E1, E2. And then also we took away M0800A through M0800F. So that's gone. And you see where that made sense, right? This is gone because you can gather the information with the current questions the way that they're asked. You're going to get that same information. So we are ahead of schedule. So what I was thinking, Mark, is that we would take a few minutes since we really want to stay on time with speakers, is that true? I was thinking we could take a few minutes for you at your tables to think about your action plans from everything we've done from this morning to this point, but especially if you can think about the Section M, just because I think that's the greatest opportunity for your nurses on your units and whatnot. But would you be able to, what education or what validation do you want to do when you go back to your organization to make sure that you're ready when these assessment items change, and make sure that your staff is prepared to answer them. So everyone has an action plan in their folders. For those of you on live streaming, take your action plan out. If you happen to have someone in your office with you for live streaming, talk that through with them. If not, I guess you can talk to yourself. I do that sometimes and write out my plan. But just take an opportunity to start thinking about not only Section M, but some of the other sections that we did this morning. Think about Med Rec and the other sections and say, what are those things that I need to do? And if you want to talk at your table about what strategies, either that you used from the last trainings that you did or ongoing, it's always nice, especially if you're sitting with people from other LTACs and other areas where they can share with you maybe a best practice or what worked for them. And sometimes I find, even though I've been doing this for a long time, I have this aha moment. It's like, oh wow, I didn't think that we could do it that way. So I'm going to give you, I think we join again at 3:30. Does anyone have a schedule? Huh? I'm sorry, break's at 3:15? Okay, so we're going to take a break so you have 7 minutes to work on your action plan. 1, 2, 3, go. And then we'll take a break at 3:15. Thank you very much.